I think based on the results, it will be a new standard of care. We have enrolled here all patients with clinical T2 to T4A muscle-invasive bladder cancer. They were cis-ineligible mainly because of renal impairment. Also, patients that declined cisplatin could enter the trial. And if you look at primary results, if you have a hazard ratio of 0.4 of reducing the risk of recurrence or upstaging to muscle-invasive bladder cancer or progressive disease precluding surgery, if you see that hazard ratio is 0.4, if you at 2 years see that 40% is only free of relapse in the control arm, and it goes up to 74% in the intervention arm. This is such an early and sustained separation of the curves that I think it should be the new standard of care. And moreover, it was translated in overall survival benefit with a hazard ratio of 0.5, and it was translated also in a key secondary endpoint of pathological complete response of 60% had an APT0 and 0. So I think this will reshape the way we treat muscle-invasive bladder cancer patients, especially the cisplatin ineligible. I think for all of them, when available, they should be treated with EVP.